So first is Professor Stefan Müller-Hülsbeck, who's going to present the first report of the Eluvia drug-eluting stent 12-month performance overall and the subgroup of diabetic patients, the MAJESTIC trial. Professor.
Thank you very much for the nice introduction, and thanks very much for being here in this outstanding conference. So you will hear now within the next 9 minutes the data from the MAJESTIC trial. I'm sure that you are not quite familiar with the trial, so I'll give you a short oversight about the patient group. We have dealt with the Eluvia stent. It's a new self-expanding drug-eluting stent constructed for the femoral popliteal arteries, and we want to evaluate the performance of this kind of drug-eluting stent in the SFA and the proximal popliteal artery in lesions up to a length of 110 millimeters. We have chosen a prospective multi-center single open label trial design, and we included 57 patients with femoral popliteal artery lesions. This trial was done at 14 sites in Europe, Australia and New Zealand, and at this point I want to highlight that no center was allowed to enroll more than 20 patients, meaning 11 subjects at all of this total study population. You are probably quite familiar with the typical follow-up guidelines, baseline procedure, 1 month, 9 months, 1 year, 2 years and 3 years. We have chosen as a primary endpoint the 9 months primary patency of target lesion, and I'm here now to present you the 12 months follow-up data, and I will include also a subgroup analysis of a diabetic subgroup. The key eligibility criteria as follows: chronic limb ischemia, defined as Rutherford categories 2, 3 or 4, de novo or restenotic lesions equally or greater than 70% in the native or proximal popliteal artery and offshore the native SFA. The reference diameter should range between 4 and 6 millimeter, and the total lesion length should range between 30 and 110 millimeter. Here's some details concerning the Eluvia stent system. As I told earlier, it's a self-expanding stent built on the Innova platform. It's a dual-layer coating consisting of a primer layer to promote adhesion to the active layer of this stent, and the active layer for sure is paclitaxel, the drug we've dealt with. And this was necessary to control release of paclitaxel, high burst release and sustained release over time for at least 1 year or even 15 or 16 months. It's a triaxial shaft design which is O35 compatible to control a very adequate deployment and to use it as a one handheld system. The baseline characteristic of these 57 patients are here as follows. I think they are typical for all the trials. All patients had typical comorbidities, risk factors, and so on. What I would like to focus on is on the baseline lesion characteristics evaluated by the core lab. And with this slide, I want to highlight that most of the lesions, around about 77%, are placed distally, some at the proximal popliteal artery. And please note that we observed in close to 65% severe calcification. The percent diameter of stenosis was in mean 86.3%, and we dealt with 46% CTOs. If we look at the primary patency rate at 12 months, then the primary patency rate with 96.1% was exceptional high. Due to the Kaplan-Meier estimate, it was even higher, 96.4%. If we compare this kind of patency rate, meaning the patency rate of the drug-eluting stent with the non-drug-eluting stent, the bare metal stent, the Supernova stent, the Innova stent, then you see there's a slight difference in terms of the drug-eluting stent technology, comparing the drug-eluting stent technology with patients, with 202 patients who received the Innova stent in the Supernova trial. In terms of safety profile, I have to tell you that we observed 2 major adverse events at 12 months, resulting in a total overall major adverse event rate of 3.8%. These had been 2 TLRs. No new TLRs between 9 and 12 months. Note that 9 months was the primary stent patency endpoint, and stent integrity was well. We observed no stent fractures. Of utmost importance for the patients is the outcome, and 94% of the patients were classified in terms of the clinical symptoms according to the Rutherford category 0 and 1 at 12 months, and the ABI improved sustained through 12 months. If we look now a little bit closer to the subgroup of diabetic patients, we noted that we have included in this trial 20 patients suffering from diabetes, and they had also a mean lesion length of 77.7 centimeters, with severe calcifications in 75%, and these lesions were mainly placed distally and 75% distally in the SFA, or the proximal part of the SFA, and the patency to the foot can be highlighted as follows: that in 10% no infrapopliteal vessel was patent, in 35% only one vessel was patent. So the preconditions for patency are probably a little bit limited. And I was really astonished when I noted the medical history that 90% were smoking, close to 90% suffered from hyperlipidemia and hypertension. That was really astonishing for me. But I was wondering, when we look at the patency rate, in all of these patients which had been evaluated, we observed a patency of 100%, and no TLR were noticed in these kind of patients. This was really amazing. So the conclusions obtained from the MAJESTIC data at 12 months are so far very, very clear. The Eluvia drug-eluting stent in the femoral arteries showed a primary patency rate of 96.1% at 12 months. We observed only 2 TLRs, resulting in a TLR rate of 3.8%. The data show a high patency and excellent safety profile achieved in the challenging subgroup of diabetic patients. We observed no stent fractures in the overall patient group of 57 patients, and patients exhibited symptomatic and hemodynamic improvement through 12 months. This is of utmost importance for our patients. And last but not least, Eluvia's paclitaxel polymer combination may provide a long-term benefit over the bare metal platform. Thank you very much for your attention.
Thank you very much. So to begin our panel discussion, let me first introduce our member of our panel, Mark Burkett, who we already met. Mark actually was one of the graders with us and has really given us a lot of help on this. Always a clear thinker. Ken Cavanaugh, a great friend of VIVA from the Food and Drug Administration, and we're very pleased to introduce Rie Fukaya from PMDA in Japan. Grateful for your trip over here to be with us. So let me just start off by asking you, Professor, one question, and I'll turn it over to Mark and the panel. So what is it about this device? I mean, these are incredible results. We're going to hear all week people saying don't leave anything behind, and yet here's data that we just have never seen before. What is it about this that you think leads to such amazing results?
Yeah, first of all, I want to express that I was also amazed about these results, because these have really overestimated our exceptions, and especially in combination with the discussion we have nowadays, don't leave anything behind. I think it's good to have these data available. We have also the silver PTX data available, because in certain situations, and this was highlighted by the previous presentations, I think there is still need for an implant, for a self-expanding 90-node stent. And probably having these kind of data, meaning self-expanding 90-node stent, which might fit in the SFA in combination with paclitaxel and a polymer, I personally have no concerns to use a stent in the SFA in dedicated lesions where PTA in combination with drug-eluting balloon technology would fail.
So these results are really remarkable. Congratulations on a great presentation. One of the things that has always been one of the emphases of the use of paclitaxel is that short-term exposure results in a long-term result. which is why, for example, drug-eluting balloons are effective and the basis of the Zilver PTX with immediate release. Do you think that maybe we need to rethink the benefit of a slow release of paclitaxel, and that perhaps the polymer and the slower release accounted for a substantial improvement?
This is a very good question. Thank you very much. I think this is of utmost importance to think about a slow, and we also can call it a sustained release, because this is something we want to achieve. If we have to deal with an implant like a self-expanding stent, then we have to look for endothelialization, for controlled endothelialization. And with this kind of stent design, with the combination of polymer and paclitaxel, we have some kind of high burst release when we need it, because when we have injured the artery with predilatation with our implant, we need a high burst as with a drug-eluting balloon. But then, and this is something I'm really convinced by, we need some kind of sustained drug release over the time, because we need a controlled process of drug release for controlled endothelialization. And we know that in the SFA, the cascade of restenosis is a little bit different from the coronaries. There's a peak at 12 months, and the coronaries there's a peak at 6 months, and therefore it was decided to design a release design which controls drug release over 12 months or even a little bit longer, up to 15 months. And probably based on that, we have obtained these kind of exceptional data.
Well, thank you very much. I think we could probably go on for quite a while with those exceptional data. Thank you very much for your presentation.